Welcome everyone to part 2 of our 3-series webinar on Casa Colina spine program. Today you'll be hearing from Dr. Martinez, pain management and physical medicine and rehabilitation doctor. Dr. Martinez specializes in the use of injections, blocks, and other interventional methods to treat musculoskeletal conditions of the spine. But before we turn it over to him, we want to remind all our viewers that there will be a question and answer session at the end of this presentation. Questions can be submitted if you're watching this webinar from a desktop or a tablet. Unfortunately, mobile phones do not allow for submitting questions at this time. We'll now turn this over to Dr. Martinez.
Thank you, Lourdes. Hello, I'm Dr. Martinez, and I'm here to speak to you about the interventional pain management portion of the Casa Colina spine program. Hopefully you were able to attend Dr. Wong's presentation last week, and look out for Dr. Giovanni's presentation next week. The Casa Spine program is a collaboration of different specialties to help address all of the spine needs of our patients. So the interventional part of it, that's my portion, and I'd like to tell you more about it. So some people refer to me as a pain doc. Maybe you already have a pain doc, or maybe you've heard about people seeing pain doctors. And I just like to specify that I'm an interventional pain management doctor, meaning I'm specially trained with additional fellowship training after my residency to subspecialize in pain management. So that allowed me to become board certified as a pain management physician. And as far as the term interventional, that's key, because that allows that is the part of the pain management that gives me my training to perform minimally invasive types of procedures. So typically, when I do different types of pain management procedures, I'm using really skinny needles. Quite often I'll hear patients when I met them for the first time and they ask, well, how big is the needle? Is it really big? I've heard they're kind of big and scary. And I try to reassure them, because the needles are absolutely really skinny. They're so skinny I can actually wrap one around my finger like a wire. And that allows them to be steerable. And since they're steerable, I get to use fluoroscopic guidance so I can get to the right spot. Additionally, since the needle is so small and skinny, and I'm not using scalpels, I don't need to use sutures, all of my procedures can be done on an outpatient basis, which is a really nice option for getting such an interventional treatment option without having to be in a hospital setting. So when are pain procedures used? Hopefully when you're on your road of being evaluated, you'll come across physicians that are aware of what a pain physician is. And in our spine program, obviously Dr. Sangnal and Dr. Wong are well aware of what I can do. And so we work as a team. If somebody's tried more conservative treatment options, let's say they've started off with physical therapy, or maybe before they got into our spine program, they've tried chiropractic and acupuncture, massage, and all sorts of other things you can try from a conservative standpoint, then maybe something I offer can be helpful. So just as an example of a few things I do, we don't want to bore you with all the details of everything I do, but the most common procedures I'd like to share with you this time. Epidurals. So I'm sure you've heard about an epidural steroid injection. Most people have, and they're quite different than the epidurals that moms have during labor and delivery. So we have a couple different approaches. Let me see if I can have a pointer over here. One type is an interlaminar approach, where we go in the middle here. And we do those when it's necessary to get a broad distribution of the pain medication. But one of the more common ones that I do, because it's more specific, are transforaminal epidural steroid injections. And with that approach, we come from the side using a very skinny needle. If you can see the lower picture, I'm not sure if you can see my mouse, but if you can see the lower picture, that's the x-ray, and you see that tiny little wire looking thing, like I said, it's like a wire. It's very skinny, and I can actually guide it right to where I want to go under live x-ray guidance. So I'm stepping on a pedal, watching the needle approach nice and gently and slowly, and I get into that space. And right next to the needle, if you're still looking at that lower picture, there's a dark band. That's actually contrast. And the contrast shows me where the medicine is going to flow. So when I'm happy that the contrast is going exactly where I want it, then I put the medication, which typically consists of a steroid and a numbing medication. So the reason why we do epidurals is for that shooting leg pain. Most people will talk about, I have sciatica. Well, medically, we call it radiculopathy because the nerve roots, now, if you look at the top picture, there's some yellow nerve roots up there, right in here. And this picture actually shows a bright little red spot, which indicates inflammation. Now, it's just a cartoon, but it's to help illustrate inflammation of the nerve root. And that process we actually call radiculopathy because radic is the Latin root for the word root. And when the nerve root gets inflamed, the pain can begin. So most of the symptoms people will describe as sciatica going down the leg. Now, the sciatic nerve itself has many different areas of distribution. And what we like to do is more specifically treat that source. So many nerve roots can actually contribute to the sciatic nerve. And so we try to focus on the specific nerve root that is involved. And by using a very precise type of injection, we can actually deliver steroid right along that nerve root. So if more simple treatments haven't helped, or if the sciatica is so painful and you can't do physical therapy, or the physical therapy is hitting a plateau, then an epidural might be helpful to kind of push you along, help you make some gains there. Another type of injection I do is this is a very common one. They're called facet joint injections. Now the facet joints, these typically cause low back pain. Now they cause low back pain without the shooting sciatica pain. So when folks come in to see me and they got all that back pain and maybe they had a disc bulge somewhere and the surgeon says, no, you don't need surgery, not for your disc. It might be your joints. We're talking about these little joints back here. Let me see if I can pull that mouse on there. So right in here, there's a joint, and I'm not sure if you can see the picture. It might depend on your display size, but there's a small little black line right there, and that's actually the needle. That's me blocking that facet joint. There's a couple different ways I can do it. One way is I can actually put medication directly into the joint space, and if I put medication into the joint space, a steroid can actually stay there and calm down inflammation. And we use that most typically in younger folks. Maybe they had a sports injury or a major trauma, and we need to just cool things off pretty quickly. But if the pain's more chronic, it's been there for years, then we have the option where we actually do what this picture shows, where we're actually taking that needle and placing that tip right along this little groove right here. I know it's hard to see. I look at these all day long, so I kind of take it for granted that I can pick this stuff out. But there's a little nerve that runs right along that groove, and that's called the medial branch. And it carries the pain signal from the facet joint. So if I block that nerve, it can help us decide if that joint is indeed the source of the pain. This really helps out our surgeons because sometimes the surgeons have to decide whether or not a back is surgical or not. If it's not surgical, then we have something we can do other than going after the discs. Now, if I did block the nerve and somebody got significant pain relief from blocking those joints, we have an option called radiofrequency ablation. And it's a mouthful, but I just want to give you a brief overview without scaring you off with this amazing picture here. This kind of scary looking picture. But what we do is we lay needles along those nerves. Now, just so you know, this is a cartoony picture, and these nerves are actually quite big looking, but the nerves are actually very tiny, the ones we're cauterizing. And the whole procedure of cauterizing these nerves is still done as an outpatient procedure. It's actually not that uncomfortable. I lay down a ton of numbing medication to block that nerve before it's cauterized. But when we do radiofrequency ablation, we can get up to, on average, 12 months of pain relief. Sometimes we need to do it sooner, and most insurance companies and Medicare allow us to do it after 6 months. But I commonly see this last well over 12 months, and it can be repeated. Maybe you've heard about sacroiliac joints, but a lot of folks haven't. This is actually one of those pain problems that's quite overlooked. And if you take reference, if you look at this X-ray right here, off to the right side of that picture is the lumbar spine. And then if you look in the lower left-hand corner, at the bottom, you can't quite see the hip, but the hip is down below there. So when people walk in with this pain, many times they're grabbing their buttock and they're saying, my hip hurts. But it's actually well above their hip, but below their lumbar spine. And that's where the sacroiliac joint lives. It's a strange joint. It's really not meant to move a whole lot. It's pretty narrow. It only has 1 or 2 degrees of motion. And over the past 10 years, more and more doctors have started identifying it. But before that, there were people that were going years without ever knowing that that joint was hurting. Now, sacroiliac joint pain doesn't have a great surgical treatment option. There are some options out there, but they're not great. And so typically we want to manage this with a conservative approach. Most people can get away with getting this treated by a physical therapist, a really good one. One that knows manual mobilization, like the physical therapist over at Casa Colina. I'm not sure if you had a chance to listen to Tom Ponce yet. Maybe he spoke at Dr. Wong's presentation, but he knows how to mobilize these joints, and he does it. He does a really good job. So if he can get it without any additional intervention, that's the first approach. But sometimes these pains just continue, and we can inject the joint. We actually do it under X-ray guidance with a skinning needle again, and all that dark material see in the middle, that's actually the contrast outlining the interior of the joint. And it's kind of spread out because this is actually after the steroid has been placed in there as well. But another weird thing about sacroiliac joint, it mimics pretty much every other type of pain. It mimics disc pain, facet joint pain, sciatica, piriformis syndrome. It is the great mimicker. And but it's not that hard to diagnose if somebody knows what they're looking for. All right. So the purpose of the injection would be to calm down inflammation of the joint. And many times, if you've been having trouble with this joint, a good physical therapist might actually pick it out for you too and say, hey, you know what? Why don't you go see a pain doc, because the sacroiliac joint seems like it's causing your problems. So we can help you along with your therapy efforts. Now, another type of procedure that pain doctors do, and I actually do this one in conjunction with the neurosurgeons, because I do part of the spinal cord stimulation process, and the neurosurgeon does the other part. The first part requires a trial where I actually place electrodes in the spinal canal. You can actually see this green area, and so we place electrodes in that area so that the electrodes can stimulate the spinal cord to disrupt the pain signals. It's pretty cool. This is actually one of my favorite things that I do. The reason is probably has a lot to do with the fact that people that need spinal cord stimulation, they've tried everything else. Many times they've been through years and years of pain treatments. Maybe they've had multiple spine surgeries, and many times I'll see folks that have had, for the first time, seeing folks that have had surgery, 5 surgeries, 4 surgeries, and maybe they worked, maybe the pain just kept coming back, and at some point you got to say, no more surgery. I think it's much sooner than 4 surgeries or 5 surgeries, but spinal cord stimulation can be a really good option. And the idea of spinal cord stimulation is all about disrupting or blocking pain transmission at the spinal cord level. So there's multiple companies that make spinal cord stimulators. If you look at that device right there, they're about the same size as a cardiac pacemaker. Now there's I'm not going to name the companies, but all the different companies, they're continuously evolving. So at any given year, one company might be the one that's kind of considered the most technologically advanced, but all you have to do is wait another couple of years and another company is going to be on top, because they're continuously evolving, continuously pushing the edge, which is awesome, because we like to do the most for our patients. So if they can come up with solutions to make these devices work even better, well, we're happy to encourage that competition those companies have. If you look at the picture on the left and you see the wires, they have these little electrodes or these little bands. I'm not sure if you can see the bands there, but there's little bands, and those are the electrodes. Now this setup is actually meant to go through a needle. So when I do a trial, I'm placing the needle and then passing the wire through that needle to get into that spinal canal. And this allows this trial to actually be like a test drive. So you don't actually have to be stuck with it the rest of your life if it turns out you don't like it, which is actually pretty huge in the arena of implantable devices or any kind of surgery. You usually can't try a surgery out first, but with a spinal cord stimulator you can, and that's cool. It also makes it so that there's, we're going into it with an open mind. The patient doesn't feel like they have to make that huge commitment ahead of time. If the trial is successful, I slide these wires out and we ask the neurosurgeon to implant the device, and they actually place a slightly wider looking electrode. It's called a paddle lead. It lays a little bit flatter and is surgically implanted. And it's typically a very quick surgery. That's a same day surgery. People go home the same day. So what to expect if one of your docs says, you know what, you need to go see the pain doctor. Let's say you saw Dr. Wong and you've tried physical therapy, and maybe there's some of those pain barriers that I alluded to beforehand. When they say, you know what, we'd like you to see Dr. Martinez. He's a pain management doctor, and we think he may be able to do an injection to help your pain. The first day I see you, we're actually not going to do an injection. And the reason is, I need to get to know you. I need to evaluate you. I need that consultation. I need to hear your story. I need to know what's going on, how your pain started. And obviously, I'm going to get some information from Dr. Wong too. But you'd be surprised as the patient talks more about their pain, we do get more details for each time. So I really need that consultation. I get my hands on for my own physical exam so I can see where I might find a weakness that's very, important in relation to a pain problem. Some of the physical exam is just to confirm what we might already know, but some of it's also to make sure there aren't any other types of red flags I need to inform the surgeon about, or maybe I might need to order new imaging. Typically the first day, I will personally review x-rays, MRIs. I actually want to look at the pictures. Reports, they're good, but I like to tell my patients a report is like somebody else describing a picture, and I gotta just take their word for it. I want to see the pictures. I want to see the MRIs. I want to see where that stenosis is. I want to see where that nerve is being pinched. I want to see which disc bulge is not just bulgy, but maybe it's torn. Maybe it is herniated, and the radiology read is a little bit more conservative than I would say. So when I look at those MRIs, I do share the images with my patients because I want them to know the same things I know. Otherwise, I'm not quite sure how people make a really strong informed decision if they're just taking my word for it that there's a disc bulge at L4-5 and it's pinching the nerve coming out from the side. So with all that, then we come up with a good recommendation. And it might still be the same injection that Dr. Wong recommended, but at least now we know why we're doing it specifically and you're on board. What to expect before a procedure? Well, in my office, I do the procedures all within the same office I see you for the consultation. We're practicing social distancing with ongoing COVID-19 pandemic. Specific to the procedures, we do require you to have a driver. A lot of times people say, oh, I've had an epidural before, but I was able to drive afterwards and my legs were fine. The problem with that is, what if your legs aren't fine? What if you don't know where your foot is in space and you go to hit the pedal, but your brain doesn't know that your foot's going for the gas pedal rather than the brake pedal? So the day of the procedure, no driving, not even if you feel completely normal. The next day is typically okay. When I do the procedures in my office, you don't need to get undressed. Typically, if we're working on your low back, we just need to raise your shirt up a little bit and your belt line just a little bit to prep the area of your back. And if I'm working on your neck, we might ask you to wear a low cut tank top or something that we can move out of the way to prep that area. Or if you're a gentleman, we may ask you to take your shirt off and we'll put a paper gown on instead. But typically there's not a whole lot of undressing happening because all we're doing is we're taking a tiny little skinny needle and putting it in a tiny little spot. So we don't need to expose everything. The visits are pretty quick, typically under an hour. And then after the injection, there's definitely going to be some numbness where I injected because I add some lidocaine to that area. There's going to be some mild soreness the next day. It may be some of the same pain you had beforehand, but typically it's not worse. And the steroid might take 2 to 10 days to take effect. That's because the steroid is trying to calm the inflammation down. And just like the problem started and it took time to start to get really bad. Many times people will notice that in the evolution of the pain. The steroid needs to reverse that and calm down the inflammation. And then the day after the procedure, I typically don't have any restrictions on board. It was just an injection, wasn't surgery. I wasn't removing anything. And about 2 weeks after the procedure, I want to see you for a follow-up because of that 2 to 10 days length of time it takes a steroid to take effect. So I want to see you 2 weeks afterwards to make sure, that we made some progress, and then we can reevaluate you then. So the follow-up visit, it's pretty straightforward. We're going to talk about your pain again. We're going to talk about the progress of the injection. We're going to talk about any side effects that may or may not have happened. We're going to document your outcome. So later on, when the insurance companies are saying, "Oh, we don't want you to have one of these treatments again," we can point back and say, "Hey, you know what? This actually really helped this person's pain." And then at that follow-up visit, even if you are feeling better, we still want to discuss rehabilitation issues. Many times we still need to exercise our body, get things working again, because maybe you've been limping around for 3 months and everything's just either atrophied or tight and restricted. So we want to come up with strategies to avoid re-injury. We may consider other parallel treatments. That might mean more physical therapy. People don't seem to get too excited about that, but man, when they go back and they feel better, all of a sudden they see that there's not the same barriers and they can actually make progress again. Let's say the injection didn't quite help as much as we wanted it to, and maybe we need to talk to a surgeon. So that's at that follow-up visit, that's when a referral will be created. And then we have all the documentation to help support that referral so that the surgeon or any other specialty, let's say you come back and you're like, "Oh, my knee hurts, so we need to get you over to ortho." Well, then we have that, packaged up referral ready to go so that the ortho surgeon or orthopedic surgeon or the neurosurgeon knows what you're dealing with. It helps them out a ton. All right, so that's my presentation. Hopefully it wasn't too much. I have a tendency to go on and on. Thank you for attending.
All right, thank you, Dr. Martinez. With that, we have a couple questions that came through, and we're gonna go ahead and start with the first one. The first question is, what is a trigger point injection?
A trigger point injection is a needle procedure that's meant to break up a very taut band of muscle. Now, that taut band of muscle, in order for it to be called a trigger point, when pressed, it needs to send pain to a wide spread area. So it's not just a tender spot, it's a triggering mechanism. And when we do injections for trigger points, I like to reserve them and only do them if somebody's really already done a comprehensive physical therapy program to stretch the muscle, because number one, that's going to be the best treatment. If we get to the point where we have to start sticking a needle in a muscle over and over again in order to break it up, that's also going to be uncomfortable. But sometimes it's necessary, but I use them very judiciously.
Okay, great. Second question. I've had epidural injections in the past. How many can I have in my lifetime?
There's not really a lifetime limit to epidural steroid injections. Typically, there's a yearly limit. We want to keep it within not more than 3, maybe 4 epidurals in a given year. It really depends on the spacing and the timing of them. But the reason that is because there's some folks that just can't have surgery, and we do need to do epidurals indefinitely to manage their pain. And so it is safe to repeat them. Typically, we always reevaluate after an epidural, and if we can wait longer before the next one, we try to space them out. It really all depends on the evaluation.
Okay. Next question. I have a history of sciatica on and off for about 10 years. Would an epidural help me? And if so, what should I expect?
An epidural may be an appropriate treatment option, but we don't know that yet unless we actually evaluate you first. So going back to the consultation, the examination, and the imaging, 10 years of sciatica, that's really tough. And I would hope an MRI is available. If it's not available, then one can definitely be ordered and justified to be ordered. So, I mean, sometimes people worry, I can't get an MRI, but 10 years of sciatica kind of justifies it. And once we get all that information, evaluate you, look at the imaging studies together, then we can decide what's most appropriate. It may be an epidural, it might be something else.
Okay. Our last question that we have is, if I am currently seeing a pain management doctor, can I change to the Casa Colina program?
Well, just like any other industry, second opinions, other opinions, that's fine. It's welcome. Sometimes you just want to, get a fresh set of eyes on it. That's okay. I would just suggest, contacting Casa Colina Spine Program, asking them to see the doctors, and if there's something if everything you're doing is great, and you don't need us beyond a consultation, that's fine. If there's something we can add to your care, we'd be happy to help.
Okay. Once again, thank you, Dr. Martinez, and to everyone who joined us tonight. If you have any additional questions that were not answered or would like some additional information, please contact the number that you see on the screen. There's also a website for additional information on the spine program here at Casa Colina. Don't forget to join us next Wednesday, March 17th at 6 p.m. for the final webinar of this series with Dr. Gabani. Have a good evening.